So I'll go ahead and get started. Looks like there's a fair amount of folks here.
Sure.
So today's topic is a review of mechanical ventilation and then some new information for you all on ARDS, pathophysiology and management. No disclosures. So first, review ventilator mechanics. I know that some of you have seen this portion of the lecture. I think it's part of the critical care lecture series, but it's good to review this for those of you that will be rotating through ICU. So I'll be talking about the mechanics, the setting, and then ongoing monitoring and vent troubleshooting. Talk about ARDS, in particular ventilator management of ARDS and troubleshooting of that in particular, which has become a daily struggle in the ICU with all of the ARDS we're seeing from COVID. So the ventilator works by providing a positive pressure gradient to deliver flow. So as you can see with normal inspiration, diaphragm expands, creates a negative pressure in the chest. Flow goes from high to low pressure until pressure equalizes. That makes the tidal volume happen. Where the positive pressure ventilation uses a drive pressure to create that pressure gradient and deliver flow. And the difference in the pressure between the airway and the alveolar space is equal to the flow times the resistance. So if there's higher resistance, the flow is going to be lower, and the tidal volume generated is based on the flow and the amount of time of inspiration. And the tidal volume, time, lung compliance, and pressure gradient here. This equation is important because, as we'll see in a little bit, it gives us information about what creates the different pressures that we measure in mechanical ventilation in the lung. So this is the entire pressure in the respiratory system. This component here is that generated by the lung compliance and how much tidal volume is in the chest. This portion is based on the flow and the airway resistance, and then the PEEP that we add is added on to create the total pressure. And so if you measure at the point of highest flow during inspiration, here you get the peak airway pressure, which is a sum of everything. If you measure it at the end of inspiration, where you have a chest full of tidal volume but no more flow, that's where you get the plateau pressure. So that's this plus this. And then finally, end exhalation, when you have no volume in the chest and no flow, these parts go away and you should be left just with the PEEP unless there's any air trapping. The ventilator has cardiovascular effects that's generated by the pressure that is put into the chest, both the PEEP and the drive pressure. The increased juxtacardiac pressure here actually augments LV and RV systolic function, makes it easier for them to squeeze. You can see the afterload reduction in the LV here. It also compresses the great vessels, decreasing venous return, so it can result in hypotension if the patient is preload dependent, like for example, somebody that's volume depleted will become hypotensive more quickly while on mechanical ventilation. And in addition to that, it causes increased pulmonary vascular resistance and increased RV afterload because of the pressure that's placed on the capillaries via the alveolar units where the gas exchange occurs. So, and in addition, from a lung perspective, the pulmonary shunt is decreased because of opening up alveolar spaces that may be atelectatic or filled with pneumonia or protein in the case of ARDS. And so you can see that the cardiovascular effects, hopefully, unless the patient is dry, lead to an overall increase in oxygen delivery, which is our goal. So the modes here, people ask often what's the best mode. Really, they can all be changed to meet the same goals of ventilation. So they can provide minute ventilation, tidal volume, pressures all similarly. And the ones you should be familiar with are the assist control modes, volume control and pressure control. These are ones that will show up on medicine boards. These are the ones that we most often use for mechanical ventilation. The Hamilton ventilators that we use call it continuous mandatory ventilation and pressure continuous mandatory. If you're reading, you may run into some of these other nomenclatures for the ventilator modes. We'll also talk about pressure support ventilation. And I forgot to update the slide. I'm getting rid of this part because nobody ever uses it anymore. I think it's finally dead. So I'm including apvCMV or PRVC mode instead, which is something that we use fairly often, and you may see me use it quite a bit actually in the ICU on ARDS patients. So the continuous mandatory ventilation mode, what we set is the respiratory rate, tidal volume, peak flow, PEEP, and FiO2. And the tidal volume and the respiratory rate setting is going to ensure a minimum mandatory minute ventilation. The peak flow setting is how quickly the breath goes in. The patient on continuous mandatory ventilation can trigger a breath either by inspiratory effort or by time. If a breath hasn't been taken in long enough, the ventilator will trigger based on the set respiratory rate. The delivery is a volume cycled breath, and what that means is the ventilator calculates how much pressure it takes to generate the volume needed and averages that and over 3 breath cycles, and then will continue to deliver that pressure as long as it's the pressure necessary to get that tidal volume put into the chest. Unless the peak pressure limit is exceeded, in that case, depending on the ventilator model, it will either limit the volume or it will deliver the volume, and then when the peak pressure is exceeded, extra air will be vented out and the ventilator will honk with a peak pressure alarm. And the breath is stopped when the set tidal volume is reached. So in a volume control mode, since tidal volume is the independent variable, the vent's going to do everything it can as a computer to deliver that tidal volume, and that includes changing the pressure. And so the airway pressures become the dependent variable, and airway resistance based on the peak flow set and the intrinsic properties of the bronchial tree and the lung compliance will be the factors that actually make up the airway pressures that we measure. So a patient with stiff lungs and higher tidal volumes will have a much higher plateau pressure. Patients with bronchospasm and a higher peak flow will have much higher peak airway pressure. Pressure control mode it differs from volume control in the sense that pressure here becomes the independent variable. So what we're setting is a drive pressure and an inspiratory time. So the ventilator is going to give a consistent amount of positive pressure over the set time, and this can either be set in seconds or as an inspiratory to expiratory ratio. Trigger is the same. The delivery is actually a time cycled breath rather than a volume cycled breath, and the delivery of the breath is stopped when the inspiratory time is reached. So pressure being the independent variable here, tidal volumes actually become dependent. So in a pressure control mode, based on lung compliance and airway resistance, remember they're dynamic, you can have variable tidal volumes. For example, if a patient has bronchospasm all of a sudden and the airway resistance increases, they're going to get smaller tidal volumes. The vent is not going to compensate to increase the tidal volumes because you've set it just at one drive pressure. Likewise, let's say you have a patient with stiff lungs from pulmonary edema, you diurese them, the lung compliance gets better, the pressure is going to be the same, tidal volume is going to increase if lung compliance improves. This apvCMV mode, often called PRVC, which is pressure regulated volume control, some ventilators call it VC+, is kind of a hybrid between pressure and volume control. And actually you set a tidal volume, a maximum peak pressure or drive pressure in an inspiratory time rather than a peak flow. The vent cycles just like a pressure control mode on a time cycled breath, but the ventilator will change the pressure to meet your tidal volume goal. And the waveform of a PRVC or apvCMV mode looks a lot more like a pressure control waveform in terms of pressure and flow than it does a volume control. And I find that useful because you can get lower peak airway pressures with this mode and deliver the same tidal volume. So if you're having a patient that already has very high plateau pressure and is having peak airway pressures in the 50s on a volume control mode, changing to this mode can actually decrease that peak pressure because the volume is delivered more consistently over the breath. Just like in a volume control mode, tidal volume is the independent variable, so airway pressures become dependent. And it is important to make sure that you pay attention to your maximum peak pressure alarm, because this mode actually will limit the volume given if your peak pressure it calculates that it's going to be too high. And that's where it's kind of a hybrid between a pressure and a volume control mode. But I find that if you are paying attention and set the alarms correctly, this really delivers a dependable minute ventilation to a patient with the favorable pressure curve of a pressure control mode. And finally, spontaneous or pressure support ventilation. This is what we use for SPTs. What you set is an inspiratory pressure or drive pressure. You set a PEEP and an FiO2, and you notice that I wrote IPAP and CPAP here because this is really analogous to BiPAP, non-invasive setting, is PSV. And the only trigger to a breath is a patient making an inspiratory effort. It delivers a flow cycle breath. So based on the peak flow from the drive pressure and the patient's inspiratory effort, the breath will stop when the flow decreases to a set percent of the peak flow, and that the default is 25%. And that's to prevent the vent from giving an infinite breath, which would be bad if you're trying to do an SPT. So this mode takes more patient effort because they have to trigger every breath. And it's used for SPTs, but also can be used for ventilation in more awake patients. For example, patients with tracheostomy that are on sedation, or patients that are awake and otherwise on minimal sedation. This is the most comfortable ventilator method because there are no mandatory breaths, which patients often find uncomfortable. And the tidal volume and airway pressures, there's a minimum from the IPAP set, but patient effort really helps dictate the tidal volume and airway pressures. And generally, the support settings we use for PSV are pretty low, so the patient's effort will really do most of the work in terms of generating a minute ventilation. So initial ventilator settings, after going through all of those, how do you set up a vent when somebody's just intubated? And really the most important thing here, because when someone's intubated, we sedate and very often paralyze them, set the respiratory rate based on your initial estimation of their ventilatory demand. So if they're a patient that is in septic shock that was breathing 30 times a minute prior to intubation, you want to set the rate higher, 25 to start, for example. If they're a patient that was intubated for airway protection after a seizure, but they have no other physiologic stress going on, then you can set the respiratory rate 15 or 16. The tidal volume to start is 6 to 8 mils per kg, ideal body weight. The peak flow and the PEEP settings initially are based on the clinical situation. If you have a patient that you've just intubated for ARDS, sure, you're going to have a higher PEEP than 8 to start. If you have a patient that has obstructive lung disease and is going to need more time to exhale, you want a higher peak flow to deliver breath more quickly. And always set the FiO2 at 100 to start and scale back from there, because I imagine in an ICU setting, when you're intubating somebody, hypoxemia is often an issue. And even if it's not, just because you're setting up a new way for the patient to breathe, make sure they're getting 100% oxygen to start. Keep in mind that patients with airway obstruction, COPD, asthma require adequate expiratory time. So your initial setting should ensure that the patient has enough expiratory time, which you can give them additional expiratory time by setting a lower respiratory rate, lower tidal volume, increase the peak flow, which decreases inspiratory time in a pressure control mode. Patients with airway obstruction often need more sedation early in the course to prevent coughing and the irritation of feeling the higher pressures in the chest, and also scheduled bronchodilators. Patients with asymmetric lung disease, this is a pretty dense right lower lobe pneumonia here. They need lung protective ventilation in the sense that you want to avoid very high tidal volumes. Even though this isn't ARDS, you want them more on the 6 to 7 mils per kg side, ideal body weight for tidal volumes, because the flow is going to go to the areas of least resistance, which means that the good lungs will get a disproportionate amount of the tidal volume, and that can cause volume trauma. PEEP can help provide flow to this consolidated portion. If you're having issues with hypoxemia in somebody with asymmetric lung disease, put the good lung down to improve the VQ matching, because if the patient is on their left side in this case, there will be more blood flow to the dependent portion and less to this portion, and that'll decrease the shunt fraction. Another point on asymmetric lung disease, when you're replacing central lines, put it on the side of the sick lung, because if you're replacing a central line and injure the good lung, you're in trouble. So that's something to think about when you're placing lines. I know I always talk about going on the left preferentially to keep the right open for the Quentin catheter that may be coming eventually. But in the case of asymmetric lung disease, right side on this patient is where you want to put all the lines to start. So ARDSnet ventilation, which I'll get into more in the ARDS portion of this talk, really fits most patients with ARDS pretty well. What it involves is a sliding scale of PEEP and FiO2. So when you're starting at a higher PEEP and a higher FiO2, it gives the respiratory therapist guidance for increasing or weaning. And you notice the oxygenation goal for ARDS, PaO2 55 to 80, or set 88 to 95. And the oxygenation goal here is different than for patients without ARDS, because the goals of ventilation for ARDS are different, where low tidal volume and low plateau pressure takes precedence over actually oxygenation and ventilation. And this is based on randomized controlled trials, the seminal ARDSnet study that was done in 2006, and the predecessor to it that was done in 2000, both really showed that there's high benefit for patients with ARDS to have low tidal volume and low plateau pressure ventilation above all else. This is for adults. For children, outcomes actually for ARDS are based on maintaining high oxygen saturation. So in case of any of you are thinking about defecting to pediatrics, keep that in mind, but please don't. So after you have your patient intubated, you've done your initial vent settings, really the most crucial time to make sure that you're meeting ventilation and oxygenation goals and not causing harm is within the first hour. Because during the first hour, you're going to see how the patient interacts with the ventilator once the paralytic and initial sedation have worn off. You'll see how they're tolerating it, and you'll also get your blood gas and see if you're meeting those ventilation and oxygenation goals. And so in that first hour after intubation, you need to get the blood gas, obviously get a chest x-ray. You're monitoring oxygenation with your ABG and continuous SATs. Make sure that the hemodynamics of the patient haven't changed or don't need therapy, such as fluid bolus, vasopressors, after you've put positive pressure in the chest. And also make sure that the patient is comfortable on the ventilator mode and has adequate sedation. And this is where we look at the peak, plateau, and in expiratory pressures again that we talked about earlier. And you see that fun equation here. So the peak inspiratory pressure is right when the tidal volume is being driven with the drive pressure into the chest. After the volume is in completely, if you do an inspiratory hold, don't let the patient exhale, you get the plateau pressure, which is a sum of the pressure from the tidal volume, the lung compliance, and then your PEEP. And then patient exhales completely. If you do an expiratory hold and don't let them inhale, you'll get the PEEP plus whatever auto-PEEP or air trapping there is. The expiratory hold value should be the same as the PEEP, and the inspiratory hold here with the plateau pressure in an ARDS patient or any patient really should be less than 30 centimeters of water. And the reason that we keep these plateau pressures low is to avoid barotrauma. This is hyperextension of the alveolar sacs that causes injury to the endothelium and capillary leak syndrome and eventually inflammation, and can cause ARDS if they don't already have it. So you can keep the plateau pressure lower by decreasing the PEEP or the tidal volume, or changing what's going on in the lungs. For instance, if they have pulmonary edema, you can lower the plateau pressure by diuresing and taking out some of that extra pressure. Peak airway pressures actually in the 50s, 60s are okay if they're needed to ventilate, especially in patients that need really high initial peak flow to get the breath in quickly, like with asthma or COPD. And then by avoiding auto-PEEP, you give that patient, as we talked about earlier, adequate time to exhale by decreasing rate, tidal volume, increasing the rate at which the breath is given. And finally, things that go along with mechanical ventilation, preventing harm from being laid up in bed, sedated with a tube, DVT prophylaxis, gastric stress ulcer prophylaxis, and then nosocomial pneumonia prophylaxis, which includes oral care and elevating the head of the bed. If the patient, after being intubated and is on the vent, has persistent hypoxemia, this is usually due to shunt. This is either due to pneumonia, pulmonary edema, and often hypoxemia responds to increasing the PEEP or FiO2, because PEEP will decrease the shunt fraction if there's any lung disease in the lung tissue, like pneumonia or pulmonary edema. FiO2 always overcomes shunt. But if you're thinking that they're persistent hypoxemia and these maneuvers aren't really working, other things to consider are heart failure, an oxygen consumption or delivery mismatch. So patients that have advanced heart failure won't respond a whole lot to increasing parameters on the ventilator because their problem is pump failure. So this is why it's good to always have the bedside echo nearby to look for systolic dysfunction. If somebody has trouble oxygenating on the ventilator, I do an ultrasound exam, both of the heart and the lungs, to see what's going on. Also, if they have very high oxygen demand and a lot of lung disease, paralytic is often a good option to decrease oxygen demand and actually improve oxygen delivery by making the respiratory cycle more efficient and take less energy for the patient. Persistent hypercapnia is always due to hypoventilation. And that means that you're either not delivering enough respiratory rate or tidal volume, or the dead space fraction is too high. And this especially is something that you'll run into in patients that you're ventilating with ARDS, because we use the low tidal volumes. And the lower the tidal volume gets, the higher the proportion of dead space, which is the endotracheal tube and the large airways is, and you end up with an alveolar hypoventilation, even though the tidal volume in minute ventilation, they're telling you, yeah, the tidal volume is 350, the minute ventilation is 11. What's actually getting down to the alveolar space is smaller than that. And so patients with hypercapnia that are hypoventilating, as long as the pH is greater than 7.2, PCO2 is improving, you really don't need to change ventilator settings, especially after you've just set the vent up. But for patients that are persistently hypercapnic, if they have ARDS, then you think, do we tolerate this permissive hypercapnia, or do I need to liberalize the tidal volume or increase the respiratory rate? Ventilator asynchrony or dyssynchrony are associated with increased length of stay and mortality for all patients, not just ARDS. And what's harmful about it is there's a rapid fluctuation in the airway and alveolar pressures, and it causes very quick recruitment and de-recruitment of places that were previously held open by PEEP, and that can cause shearing to the alveolar units. To avoid ventilator asynchrony, increasing sedation works, sure, but a lot of the time you can get away with actually changing the ventilator mode. As we discussed earlier, all the modes can really deliver the same thing. And so find out what the patient wants in terms of tidal volume and flow and try and match that. And that can often really eliminate ventilator dyssynchrony completely. If hypoxemia or hypoventilation is severe, you do have to paralyze. But if you can't really fix things with the ventilator modes, increasing sedation is pretty reliable. If you have sudden changes in airway pressure, non-delivered breaths, then it's just alarming and not delivering any breaths. This is a pretty common call. Always look at the patient first and not the ventilator. It's amazing how many times I've seen, I've been called into a room, people are freaking out, they're all looking at the ventilator, and the ventilator is disconnected from the endotracheal tube. So always look at the patient first, look how they're breathing, make sure the circuit's intact. Start with inline suction, because changes in airway pressure are often just a big mucus plug. So coughing, tube malposition, circuit disconnection, proximal mucus plugging are very common here, easy to resolve. If they're still having issues with non-delivered breaths or high airway pressure, if they become unstable, it's better to just take them off the ventilator and bag, and then get a chest x-ray to look for other causes of non-delivered breaths. If the chest x-ray is clear, consider acute bronchospasm and use bronchodilators at high doses appropriately. Any questions about that portion before I go more into ARDS specific stuff? All right. So ARDS, here's your Berlin definition that you all know. It is important to know. But remember that ARDS is really a syndrome that can be described in terms of physiologic change. It's not just a PaO2 to FiO2 ratio. And by understanding the what's going on physiologically at the cell level, the membrane tissue level, the whole organ level, you can understand what's going on, and it actually helps you treat ARDS and understand what our goals of ventilation are for patients with ARDS. So it's due to acute lung injury, capillary leak, and proteinaceous fluid accumulation in the alveolar spaces. And often these are triggered by sepsis and trauma are the two most common. Pneumonia, aspiration, and then occasionally blood transfusion. But really, we see a lot of it with viral infection lately, COVID-19. And the lung injury that occurs is based on inflammatory mediators, interleukins, tumor necrosis factor, etc., causing capillary leak and diffuse alveolar damage in the lung. So it starts with an exudative phase with interstitial and alveolar edema. Neutrophils and will go into the lung tissue and intercalate into the interstitial space of the alveolar units in particular. And cytokine production will cause loss of coagulation and fibrinolytic homeostasis, much like the physiology of sepsis in the vasculature. And then a proliferative phase after this exudative phase, which we see patients and intubate them in, is either ending up in healing or fibrosis with scarring. So the entire cycle of ARDS takes about a month. So if the patient does survive ARDS, they're often left with persistent hypoxemia and the need for quite a bit of rehabilitation. So at the microscopic level here, you can see this is what a normal lung tissue looks like with alveoli and the type 1, type 2 pneumocytes here. This is an ARDS lung, and you can see all these neutrophils clogging up these interstitial spaces and all of this proteinaceous fluid accumulating in the alveolus. And this alveolar filling here, these are areas that can't be ventilated. So these are basically shunt at the smallest level that you can see. Increased interstitial and basement membrane thickness result in a decreased DLCO, which means that it's harder for oxygen to cross the barrier between the blood vessel and the alveolus and get loaded onto hemoglobin. So oxygenation becomes less efficient, in addition to sometimes it can't even occur because of the shunt. And then inflammation and cell death that occurs means that there's less type 1 pneumocytes that actually allow for the gas exchange, and dysfunction of the type 2 pneumocytes, so less surfactant is produced, which actually exacerbates the problem of this proteinaceous filling and inflammation. Going a level up for the tissue level ARDS, the local inflammation and interstitial edema actually interfere with venous return and bronchial function, because the lungs are organized into these lobules here. If you have enough pressure from edema here inside these units, actually these pulmonary veins and lymphatics that run along them will be compressed and unable to take up as much fluid. And if the drainage is impaired, that actually exacerbates the problem of interstitial edema in the lung. Likewise, the increased pressure in the lobule can actually cause compression of the small bronchioles and make delivery of air more difficult. So it's really a kind of a vicious cycle of, think like a tiny compartment syndrome due to local lobular pressure variation. So if you have let's say this one is really affected by the ARDS and this one's relatively clear, this guy is going to be almost completely dysfunctional because of not only the impairment in the gas exchange, but also the impairment in the vascular drainage and the function of the airways. And finally, at the organ level here, really the macroscopic pathology that you see reflects the microscopic cellular injury, varying local pressures, and vascular dysfunction. There are some areas that are relatively spared, some areas that are densely consolidated, and some areas that are just kind of ground glass infiltrates edematous. And this is really this variable lung injury and severe shunt is the hallmark of ARDS. And it's interesting, the reflection of this, you see some are clear, some are not. Here you may have some lobules affected, some not, and here it's really the same thing at all different levels that are causing the physiologic changes of ARDS. So what do we do about it? Well, unfortunately, a lot of things have been tried, and the only thing that seems to really result in improvement is the right kind of supportive care. So maintaining oxygenation and ventilation without causing further lung injury is necessary to manage ARDS. And the goals are to prevent atelectasis with adequate PEEP, low tidal volume ventilation to prevent alveolar overdistension, and then keeping the plateau pressure less than 30 prevents alveolar membrane leak. And you can see if you ventilate at a high lung volume here and you get hyperinflation of these alveolar units, this actually can cause further injury to the basement membrane here and cause shearing and an additional increase in proteinaceous filling here, surfactant dysfunction, and then the development of hyaline membranes that makes oxygenation more difficult. If you have overdistension from barotrauma, so this we would call volutrauma, barotrauma here will cause injury to the endothelium and a capillary leak syndrome on its own. So if we have low tidal volume and low plateau pressures, we're not causing additional injury to the lung and hopefully ensuring our minute ventilation and oxygenation while allowing the lung to heal. The clinical course of ARDS and the requirement for the supportive care is generally between 5 and 14 days, where the patient has to get over this initial acute phase with the high pressures and a lot of inflammation and edema, and move on to this phase where a lot of the edema starts to clear and you're left with lung injury, but not such difficulty ventilating. So the lung protection ventilation being the primary goal means that it's okay to maintain abnormal labs and vitals. So PaO2 of 55 to 80 and an O2 sat of 88 to 95 is okay in these patients. Permissive hypercapnia as long as the pH is greater than 7.2 or 7.25. And this is because multiple studies have shown mortality, morbidity, and length of stay benefit for lung protective ventilation versus oxygen saturation driven ventilation. And so you can have an ARDS patient with these settings here and this blood gas, and you can be winning like Charlie Sheen is. As patients get better, you scale back on these, and the patients will actually on their own be able to maintain an oxygenation and a ventilation that you no longer need to tolerate this once the ARDS kind of resolves on its own. So as you wean ventilator settings here, You'll also see a normalization in blood gas as patients get better. This is during the acute phase where we're really focused on low tidal volume ventilation as the #1 goal. So troubleshooting ARDS ventilation when things are going wrong requires an understanding of your goals here. So, #1, you want to keep the patient alive. So we got to have an oxygenation goal and a ventilation goal with a pH. And then #1, after keeping alive, is maintaining the low tidal volume ventilation and low plateau pressure. And then other goals are to keep the PEEP pressure under 60 and avoid asynchrony. So this is kind of the hierarchy of ventilatory goals with ARDS. And unfortunately, managing one often affects the other. And you end up with a very complicated situation where you're making a lot of changes, getting a lot of blood gases, as you see with the patients that we're managing with ARDS and COVID. Always think about comorbidities and how they contribute to your ventilatory goals before you start going after just ventilator changes. Patients with obstructive lung disease always need bronchodilators, consider steroids. Conservative fluid management. You can favor pressors over additional fluid boluses and even diurese patients to keep them even to negative. Think about abdominal wall and chest pressure contributions to plateau pressure. If patients have ileus or ascites, this can cause an increased intra-abdominal pressure, which is reflected in pressure up against the diaphragm. And for patients with a lot of meat on their chest, if you will, you can actually tolerate a higher plateau pressure goal because the additional pressure that is on their chest from the obesity actually is not causing an additional stress on their alveolar units. You can actually measure with esophageal manometry an intrathoracic plateau pressure, which is the most accurate. And patients with a lot of obesity and chest wall obesity, we can reliably use plateaus under 40 for the goal, based on esophageal manometry studies. Make sure that you're treating heart failure. And finally, be vigilant for the complications of ARDS that can make things worse: pneumothorax, ventilator-associated pneumonia, pulmonary embolism. So the bar is low for hypoxemia, and you'll see a million different opinions from a million different attendings and respiratory therapists about where we need to set our oxygen goals. But if you want to go by what the book says, which I do because the book is smarter than we are, oxygen sat greater than 88 and PO2 greater than 55 is okay. And I think that a lot of the oxygenation issues that we have are unfortunately driven by different opinions of goals. Patient with a PO2 of 60, you don't need to go up on the FiO2 if you're strictly following ARDSnet protocol. If different attendings have different goals, as you guys experience every day as part of residency, one day you'll have different goals too. It's nice if you can have agreement and standardization among your group in terms of what your goals are, because that makes things a lot easier for everybody. So what I'm teaching you here is the book answer. It may not be what you experience. It is what I practice. And it's from the original low tidal volume ventilation study and then the ARDSnet study. And this has been verified on further studies over time. Cochrane Review has showed with low tidal volume ventilation, this is an okay oxygenation goal. With that said, if you're still hypoxemic, not meeting this oxygenation goal, what can you do about it? You can increase the respiratory rate actually, because if you decrease the PaCO2, you'll increase the PaO2 based on the alveolar gas equation. It's kind of like voodoo, but it works. You can increase the inspiratory time. That means making the IDE ratio closer to 1:1. That increases the mean airway pressure and improves oxygenation. And these are things you can do without having to increase the tidal volume, which you want to do as kind of a last resort in patients with ARDS, because that's what we're really trying to do to protect them. You can increase the PEEP to decrease the shunt fraction. And finally, if the hypoxemia persists, paralytic can help because it helps with oxygen delivery and smooths out the breathing. Or excuse me, helps with oxygen demand and also makes the breathing smoother and more efficient. And finally, proning can very reliably increase oxygenation. Hypercapnia is okay as long as pH is okay. pH greater than 7.2 or 7.25. The reason this pH goal is chosen is because that's at the level where you start to have dysfunction of the endogenous norepinephrine, epinephrine, alpha beta receptors. And so patients that have pHs lower than this will be more prone to hypotension, shock states with impaired oxygen delivery, acute coronary events, especially arrhythmias, and also CNS dysfunction. So as long as the pH is higher than 7.25, really it's okay to tolerate hypercapnia in ARDS patients. If your pH is getting low, you can increase the respiratory rate, increase the PEEP, because decreasing the shunt can actually improve carbon dioxide offloading, as well as improving oxygen onloading. As a last resort, you can increase tidal volume if you need to. Keeping it less than 6 mils per K ideal body weight is ideal, though going up to 7 mils per kg in the situation of a critical pH is sometimes necessary. And also make sure that there's no air trapping. We talk about lower I/E ratios to help with oxygenation. With patients with obstruction, that can actually cause air trapping and worsening hypercapnia and lower pH. To actually be able to allow persistent permissive hypercapnia, metabolic acidosis really must be avoided. And you see this time and again in our COVID patients where, initially they have working kidneys and they develop this compensatory metabolic alkalosis. You see the high bicarbs, but as soon as they have renal failure, the bicarb plummets and the pH becomes really hard to control, and we end up struggling to make up for the metabolic component with respiratory reserve that the patient just doesn't have. Avoid nephrotoxins, as we always say. Avoid renal failure if we can. Often renal replacement therapy is necessary for acidosis in patients with ARDS. And you want to treat sepsis to avoid lactic acidosis, obviously. But keep track of the metabolic panel as well as just the pH and the PCO2. As you know, it's all connected, and that's why it's hard. So the strongest predictor of a good outcome in ARDS is maintenance of the low tidal volume. So you want to always start with tidal volume less than 6 mils per kg ideal body weight. In the ARDSnet study, starting at a higher level at 7 was actually shown a 25% mortality increase at 7. So 8, 9, 10, etc. Are progressively more harmful. So if hypoxemia or hypercapnia develop, as we discussed above, they can be tolerated. To meet this goal, you can increase your respiratory rate to ensure minute ventilation. You see many of our ARDS patients on rates of 28 or higher. Really, the ceiling for respiratory rate for most patients is somewhere around 35 to 36. If the tidal volume must be increased, 8 mils per kg is the maximum as long as the plateau pressure is less than 30. And increasing the tidal volume temporarily to improve other parameters is okay, but make sure that you're actively titrating it down as tolerated so you're exposing the patient to the higher pressures and the higher volumes for as small time as possible. As we saw back in the physiology part, that acute lung injury occurs when you have high tidal volume, high pressure, and the amount of injury is dependent on the amount of time that they're experiencing that. So, you know, sometimes you run into a spot where they just won't oxygenate or won't ventilate with a tidal volume of less than 6. Bump it up, see what else you can change to improve things, paralytic, pronate, etc., and then come back down to the 6, protective lung ventilation. The second strongest predictor of a good outcome is a maintenance of low plateau pressures. Once again, you can target a little higher one with very obese patients, which all of our COVID ones are. To meet these plateau pressure goals, you can decrease the tidal volume or PEEP. You can diurese, and also paralytic can help. And as you're starting to see, for some troubleshooting, I advise increasing. For some, I advise decreasing. All of these goals are really tangled together, and you have to keep in mind the priority, which at the beginning we said, you know, you got to make sure they have an oxygenation and a ventilation that are at this minimum level, and then the next priorities are low tidal volume, low plateau pressure. Peak airway pressures really aren't a concern unless there's active airway obstruction you need to go in and fix. So you can tolerate peak pressures under 60. Anything higher than that, the risk of pneumomediastinum and pneumothorax is higher. You see all of our COVID patients that are on BiPAP getting gigantic tidal volumes, getting pneumomediastinum. Their peak airway pressures are probably higher than 60 when they're doing that. To keep the peak pressures low, give everybody bronchodilators with ARDS and even higher doses, and think about steroids if they have obstructive lung disease. If there's a very acute change, consider mucus plug and pneumothorax. And most patients start with a peak pressure alarm at 40. That's kind of what our ventilators and respiratory therapy service defaults to, but I often have them increase this so the ventilator will deliver adequate tidal volume to the stiff lungs. And in these cases, the peak is high just because the plateau is high. So you're seeing higher peak pressures, not because there's so much stress on airways, but because you're seeing the additive effect of our high PEEP and low compliance lungs causing a relatively higher plateau pressure. And finally, ventilator dysynchrony that we talked about earlier. You know, in ARDS, most of it is due to air hunger from the low tidal volumes. Very uncomfortable to be forced to breathe 30 times a minute shallow. If there's a lot of dysynchrony, you can always increase sedation, which we do. Occasionally, you can, this is more for patients without ARDS, but even with ARDS patients, see what they want. Give them very brief pressure support ventilation. See what kinds of flow and volumes they want. In ARDS patients in particular, increasing the peak flow or giving a shorter inspiratory time can actually resolve that air hunger or double triggering, because it makes the patient feel like they're getting more volume because the flow is so quick. And finally, if dysynchrony is a very serious issue, can always paralyze. And, you know, ARDS ventilation is not easy and requires constant vigilance with all of these conflicting but very important goals. So, you know, regular ventilations like this guy, and ARDSnet ventilation is like these people. That's pretty cool. Those are spinning plates for those who don't know. So we talked about all the ventilation strategies, lung protective ventilation. There's really no specific medical therapy that's beneficial for these folks. So what can we do? You know, steroids have been studied currently by most society guidelines are not recommended, though the data is fuzzy enough that it's within standard of care to give steroids for ARDS. For COVID, of course, we do, because it's the one therapy that shows a minimum mortality benefit for patients critically ill with COVID. Many immunomodulatory medications have been tried because of the inflammatory pathophysiology of ARDS, but none of these work in terms of outcomes. Often they have a lot of side effects. So really the only drug we can use to help us is diuresis, to keep the patient at even to negative, to minimize the water portion of the pulmonary edema. But once again, keep in mind, don't make the kidneys too dry, because renal failure is very bad in patients with ARDS. The mortality in patients with ARDS plus renal failure is twice as high. And obviously just supportive care here. The ABCDEF bundle for mechanical ventilation fits in nicely for patients with ARDS. We want to ensure that we support, get adequate nutrition, early mobilization, and prevention of delirium. So maybe one day one of you will invent an ARDS therapy and you'll be very rich. And just remember that I taught you about ARDS, so you can give me some of that money. So if the ventilation alone is not meeting goals of therapy, options, paralytic, there's benefit, especially if done early in the ARDS course. Prone positioning, once again, done early, and by early, I mean the first 48 hours for these two is the highest benefit. For proning, you cycle 16 hours prone and 8 hours supine. Prostacyclin analogs and nitric oxide can improve oxygenation, but in multiple studies, including patients with COVID, there's really no mortality benefit for using Flolan or nitric oxide for patients. And finally, ECMO, for ARDS in general, early data, and this was from the H1N1 flu epidemic in 2009 and then again 2011, showed benefit for patients with single organ failure done early. Later data and reanalysis of the old data didn't show a clear benefit for ARDS and ECMO, but I think that as a last resort therapy, there certainly is a benefit for a well-selected patient population, and that includes patients with COVID. So if you have a patient that's under 65, single organ failure, otherwise relatively healthy, think about referral to ECMO center within the first 48 hours if possible. All the ECMO centers in Michigan are full, and they're going to say, oh, wait, doesn't meet criteria, etc. But continue to try, because you've seen especially this wave of COVID is especially bad. Not a lot of good outcomes so far for our folks. You know, I think we had some better success treating people during the first wave where there was no Delta variant at all. And the third wave, where we had a somewhat younger population and not so much Delta. And now we've got people that are just getting stuck on the ventilator. It's frustrating. So early ECMO, hopefully we can save some more of them. Any questions about any of that at all? All right, well, I hope that you enjoyed the talk. And the next talk in the series will be about sedation in the ICU and ICU delirium.